My name is Louis Kim, and co-facilitator with Michael Pencina. And see if this works. Okay. Can I just have the members of our workshop raise your hands? I just wanted to briefly call attention to the fact that we got really lucky in terms of the expertise and the background. Sometimes with workshops, it's a little bit random. We have 2 executives from Fortune 50 insurance companies, health system executive, theologians, head of an ethics center for the trade association in the US for the 2,000 Catholic health institutions. So it was a really rich discussion. We started with first a landscape of the taxonomy of where AI intersects with healthcare because, there's kind of a predominance of sort of doom and gloom apocalyptic discussions on AI as it centers the human, but AI, like any industry, intersects in a lot of different areas. However, because of the Catholic sort of emphasis on the human, we converged on the green topics. So where a patient is involved and where it intersects with theology and spirituality and Catholic principles. Michael Pencina, my co-facilitator, will start with kind of a more near-term set of issues, and then I'll take it over on the more the long-term.
Right, we recognize that the issues are both shorter term, where do we go today, in the context of the world where the AI, the cat is out of the bag, right? And we're kind of chasing it, and our ability as Catholics to influence it has certain objective limitations, right? So how do we respond to what's happening in the world? And then also taking the longer perspective, right? So we don't miss the boat, so to speak, like with the technology that our framings and foundations are not ready. So with the shorter term perspective, what we did, we looked at the goals of healthcare in general, not just Catholic, right? But if you go to any health systems, they will say that they want to increase patient access, big issue in the US and across the world, affordability, healthcare is too expensive, and reliability in the era of AI, right? We want to deliver good and safe healthcare. We juxtaposed it with the Catholic social teaching principles, right? The ones also referenced in Pope Leo's letter to us in the first column. And then we said, okay, let's try to talk about use cases that we think it's a positive application of AI, right? Start with the good. There is a lot of kind of, okay, we fear this, this, and this, but what's good? Where do we want AI to go? And these are the examples, right? So access through personalized, democratized access tools, finding and triaging the care, right? So AI can help with that. Diagnostic auto-read, especially in under-resourced environments, right? When you don't have the doctors to process images, I think AI can be very helpful. To increase affordability, in general, we like back office applications of AI, simplifying that process, right? That nurses don't have to copy documents, but they can spend more time with patients. Claims and prior authorization, approval only, right? Technologies that lead and automate and speed up approval, we like. We don't want to give to AI claims or care denials. Remote patient monitoring is a positive. Ambient scribes, right? The scribe listening to the clinician-patient interaction. It actually makes it more personal, right? It's a very good use case that they can talk face-to-face rather than, it's my experience, many of you has been, right, the doctor typing and trying to multitask while talking to you. So AI is good as long as the clinician reads what AI produces. And AI for design of learning healthcare, right? A lot of process improvement and design of facilities. Reliability of AI, it's essential that we generate evidence, right? We're in a sphere with AI where we kind of trust it, especially in the US, where we progress to innovation and evidence generation lags other areas, either of technology or clinical research, right? When you talk about trials of medical devices, it's a much more evidence-oriented framework. And it has to happen but even more importantly, post-deployment of the technology, right? With the maintenance and monitoring focused on patient outcomes, not just the performance of the technology, but what does it do to the patient? Here is a simple example of a workflow. I modeled it on my encounter of my gastroscopy, right? From entry to exit and follow-up, all the things that happen in these stages. And we kind of said, okay, where can we have just AI where humans are essential, right? And the kind of entry, checking in the hospital, that might be automated. The prep part, I really appreciated the doctor and the nurse talking to me before the procedure, right? Then I'm put to sleep, the procedure happens. AI can do well during the procedure for the most part, as long as there is a doctor kind of overseeing what's happening. Then I'm coming back. I want to see a human telling me what they found, right? The exit, again, can be automated, and follow-up. In my instance, I got a personal call on my cell phone from the doctor telling me what they found, right? Very nice human touch that I want to preserve. Again, it could be augmented by AI in the process. And then we try to define features of good AI, kind of set of principles. We came up on 4 universal and 5 that's more specifically Catholic, right? So number 1, serves the human person. It's absolutely essential, and tries to follow the patient-clinician interaction and not replace the clinician. Humans, we get to decide where to use AI. That's absolutely critical, right? We call the shots of the technology rather than it being driven by profit or other motivations, right? We get to pick the good use cases. Humans set expectations for benefits and anticipate risks pre and post implementation. And that requires that it operates in a human-defined framework of governance with monitoring as well as transparency, right? Important component. If we interact with bots, which will be more and more present, we want to know that, right? We don't want technologies that are trying to fool humans thinking that they're interacting with another human. And then the 5th one, which is inherently Catholic, really enabling Catholic healthcare to witness to the healing ministry of Jesus Christ.
So Michael was talking about the concepts of AI in the near term with technologies and structures that we understand now. But there is a truism with technology disruptions, or cliche, that we tend to overestimate the impact and the immediacy in the short term and underestimate the long term. So we were thinking about, okay, 50, 100 years from now, how do we think about the human and AI? And this spurred a lot of debate, and we had a list of criteria for when a human is necessary in any healthcare encounter. So one is non-algorithmic. AI is very powerful and will continue to be very, very much more powerful when it comes to algorithms and solving things with patterns. But when it transcends that, I think you need a human. I won't read the entire list. I think most of this is pretty self-evident. Maybe non-impersonation, and we'll touch upon this in the next slide. An AI entity can appear to be human. It can be perceived as human, but maybe one principle is it needs to be identified as non-human. There should be no mistaking it. So we talked about, in the long term, how the church has influenced society, especially with AI, with so much capital required and capitalism, and there's only so much we can do. We don't build models. We don't allocate the capital necessary. Where the church has been really influential is in terms of influencing the culture with the vernacular, Catholic social teaching, ERDs in hospitals. So we took a stab at what might a version of something like preferential option for the poor, the common good, look like that stipulates where a human is necessary. So this is just a working kind of statement. So we came up with the Irreducible Encounter Principle. Right? And this statement incorporates a lot of the criteria that we talked about, including, at the end, Catholic healthcare is an embodiment of the ministry of Jesus. You can't replace that, right? And there are situations where you need a human-to-human encounter, divine mediation, verification. These are all sort of debatable, but at least establishes a principle. And maybe one of the things that can come out of this work, through a white paper or whatever, again, is to coin a concept that can be durable decades from now, maybe even centuries from now. Now, principle is easy to understand. In practice, there are some tensions. So in Catholic social teaching, there's an issue of solidarity and access. What if there is a hospital that has no people? It's cheap. You can plant 100 of them in some developed country. If you had to require a human to staff it, you can only maybe do 10. Where's the trade-off? And there was no clear answer. It was a debate. But this is an example where you have to go beyond what's called principalism. So we had a couple of limit cases sort of test what our criteria. One was, again, a personless hospital. What about a hospice or elder care facility that's understaffed? There's one nurse, and you have a robot that can be a chaplain for 50 people. Would you want that? And it was a divided opinion. One resolution is possibly, there's always an out. If you do have something automated and there's no people, there's always an option for an access to a human, as an example. But these are things that need to be worked out over time. Okay, so that's session 4.